Good afternoon to everyone. We are now streaming live from the University of the Philippines, Manila for the 19th Lourdes Manahan Lectures in Rheumatology. I am Dr. Heizel Reyes of the Division of Rheumatology here in UPPGH, and I will be your moderator for this session. I would like to first thank our sponsor, Pfizer, for their support of this CPD event, and all of our 270 plus participants for joining us today. You can type your location in the chat box so we know where you are listening from. During the course of the lectures, you can also post your questions in the Q&A box, and we will address them during the open forum. You will receive your certificate of attendance a week after you submit the evaluation form and post-test, which will be posted later. So, abangan niyo po yun. Okay. This is the fifth of our 8-part LMLR series for this year. The Lourdes Manahan Lectures in Rheumatology aims to teach the basics of rheumatology and also presents update. And this is in continuation of the legacy that was initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. The LMLR is also in support of the United Nations Sustainable Development Goals 3, which is health and well-being, and Sustainable Development Goal 4 for quality education. As part of this initiative to support SDGs 3 and 4, the division also has published several books this year. We're happy to share with you the publication of our Atlas of Rheumatic Diseases. This is the first in the Philippines. And for those of you who may wish to avail of the book, kindly email pgh.rheumatology@gmail.com. The email address is posted on the screen. You may also call our phone number or scan the QR code to order. Soon to come out as well is another book, The Physician's Guide to Telerheumatology. This is a toolkit for the non-rheumatologist on how to approach the initial diagnosis and management of patients with various rheumatic diseases. You may also email us to reserve your copies. Okay, let's now proceed with our LMLR. Our lecture today will focus on challenging cutaneous-articular syndromes such as SLE and psoriasis. We're deeply honored to have two distinguished speakers. Personally, to me, more than being distinguished because they're excellent physicians, I know them both to have compassionate heart. So kasing ganda ng brains at heart nila ang faces nila. The first speaker is no other than Dr. Winlove Mojica. He completed his dermatology residency here at the UPPGH and pursued further training in sexually transmitted infections at the National Skin Center in Singapore. Dr. Mojica is currently a clinical associate professor of the Department of Dermatology in UPPGH and is the consultant medical director of UL Skin Sciences Incorporated. You know him from social media as the Skin Sensei. Our second esteemed speaker is our own Dr. Geraldine Zamora-Abrahan. She completed her rheumatology training at the Philippine General Hospital as well, and is now also a clinical associate professor of the UP College of Medicine, while also serving as an active consultant in St. Luke's Medical Center, Global City, and Manila Doctor. And just like Dr. Mojica, media from Averaging. Ladies and gentlemen, colleagues and friends, let's welcome Drs. Mojica and Zamora as they share their expertise in today's lecture.
Good noon, everyone. Thank you for spending your lunchtime with us in the PGH Division of Rheumatology. I'm Dr. Geraldine Zamora, and I'm very delighted to be discussing this topic with you with our esteemed guest and my dear friend and kumare, Dr. Winlove Mojica. Hi, Mars.
Hi, good afternoon, Mars. Thank you for having me. Thank you to the Division of Rheumatology.
Okay, so next slide, please. We do not have any financial disclosures in relation to our talk, and our objectives are to discuss diagnostic clues to recognize cutaneous lesions of psoriasis and systemic lupus erythematosus, or SLE, and to discuss the approach to treatment of the said cutaneous syndromes. So dermatology and rheumatology are two specialties that deal with significant overlap as cutaneous and articular manifestations frequently coexist. So here are just a few examples. In connective tissue diseases such as malar rash and discoid rash in SLE, vasculitic lesions in rheumatoid arthritis, mechanic hands in dermatomyositis. Next slide. Telangiectasia, skin contracture and ischemia with gangrene of the digits in systemic sclerosis. And next slide. In spondyloarthritis, there is keratoderma Mojica in reactive arthritis, and the lesions of psoriatic arthritis. And in arthritis associated with infections such as in Hansen's disease or leprosy, as well as the typical nose pigmentation in chikungunya fever or the chick sign. Okay, so there are many other conditions that manifest with joint pain and rash, and this is why I almost always refer to our derm colleagues for opinion and co-management. And here is Dr. Mojica, also known as the Skin Sensei, to start off with diagnostic clues in psoriasis.
So thank you, Jane. So psoriasis is one condition that dermatologists manage with rheumatologists. To simplify, the development of psoriasis has both genetic and environmental basis. There are multiple genes associated with the development of psoriasis. However, having the genes doesn't mean you will automatically have psoriasis clinically. It is said that the genes are turned on by something in the environment. This could be stress, trauma to the skin, and weight gain, to name a few. Once activated, the immune system, through the action of T cells, promotes the proliferation of epidermal cells and blood vessels, which lead to psoriasis. So most of the time, we see psoriasis patients with dermatologists first because of the visible skin changes in psoriasis that give our patients anxiety. So the classic description of a psoriatic lesion is a red plaque with an overlying silvery white scale. It usually starts on the scalp, which can be mistaken as dandruff. The difference of psoriasis with regular dandruff, however, is that it crosses the hairline. Other predilection sites include the extensor surfaces like the elbows and the knees. Psoriasis can be triggered by any form of trauma to the skin. That's why it's also common to appear on the hands and on the feet. The appearance of psoriasis in areas of trauma is an example of Koebner phenomenon. Koebner phenomenon can also explain why psoriasis usually manifests first in the scalp, because we commonly comb our hair, and that is a form of trauma to the scalp. Psoriasis can also affect the entire skin of the body, and this also includes the nails, which is commonly missed during physical examination. So nail findings include, in psoriasis, include salmon patches, pitting, onycholysis, and nail findings are highly indicative of joint involvement since the tendon attachment of the fingers or the toes are intimately associated with the nails. So the longer a patient has psoriasis, the higher the chance of developing psoriatic arthritis. Conversely, about 1/3 of patients with psoriasis will present first with arthritis rather than skin findings, and that can be very challenging. That's why we work closely with rheumatologists. So here is Dr. Jane to discuss psoriatic arthritis in detail.
Okay, thanks, Winlove. So this is a simple tool physicians can use whenever we see patients with psoriasis. The Psoriasis Epidemiology Screening Tool, or PES questionnaire, developed to screen for psoriatic arthritis, or PSA, in patients with psoriasis. So the questions are pretty simple. Number one, have you ever had a swollen joint or joints? Number two, has a doctor ever told you that you have arthritis? Do your fingernails or toenails have holes or pits? Have you had pain in your heel? Have you ever had a finger or toe that was completely swollen and painful for no apparent reason? So 1 point is scored for each yes answer, and a score of 3 or more indicates psoriatic arthritis, or PSA, with the following sensitivities and specificities as you see in the screen. So next slide. On the other hand, if a patient presents with arthritis or enthesitis, this CASPAR criteria can help classify a patient into having PSA if there are at least 3 points from the following features. So that's current psoriasis, which is assigned a score of 2 points, and all the other features are assigned a score of just 1 point. And these include a history of or current psoriasis, or a family history of psoriasis, dactylitis, juxta-articular new bone formation in the hands or the feet, negative rheumatoid factor result, and psoriatic nail dystrophy. Okay, so patients with psoriasis will always be at risk of developing psoriatic arthritis. And the longer the patient has had plaque psoriasis, the more likely they are to develop psoriatic arthritis. Therefore, repeated screening for PSA should be carried out for the duration of care. So there are 5 clinical patterns of psoriatic arthritis, which were originally classified by Moll and Wright. Distal arthritis characterized by involvement of the DIP joints, much like our osteoarthritis patients. Symmetric polyarthritis, similar to and at times indistinguishable from rheumatoid arthritis. Number 3, the asymmetric oligoarthritis, in which less than 5 small and or large joints are affected in an asymmetric distribution. Spondyloarthritis, including both sacroiliitis and spondylitis. And arthritis mutilans, characterized by deforming and destructive arthritis. Okay, Winlove.
So it's very enlightening to know that there are 5 clinical patterns of psoriatic arthritis. Usually, we're just familiar with the distal type now. So thank you, Dr. Jing. The diagnosis of psoriasis is clinical, but there are times when the lesions do not present in a classic manner. So for example, a bad case of dandruff with very thick scales, but the lesions are not crossing the hairline. Or there are some erythematous papules, but they are not too scaly in the elbows and the knees. A skin biopsy can definitely help clinch the diagnosis of psoriasis. So here is a classic picture of a histopathologic picture of a psoriatic lesion. So there is thickening and the downward growth of the epidermis, as you will see here, with a violet coloration. And this is called psoriasiform epidermal hyperplasia. In the epidermis, you can see, if you go into high power mode, you will see neutrophilic infiltrates identified as Monroe's, microabscesses, and spongiform pustules of Kogosh. In the dermis, there is a dilated capillaries in the dermal papillae, and this is observed clinically when you remove the scale as pinpoint bleeding, and this is called the Auspitz sign. Okay, so once you see this in histopathologic section, so this is classic psoriasis. And there are other laboratory findings in psoriasis. Dr. Jing will discuss them.
Okay, thank you, Winlove, Dr. Winlove. So lab tests may be done if there is evidence of systemic inflammation and to exclude other conditions, although of course none is diagnostic. If a blood count shows anemia of chronic disease, this points to more urgent need for treatment. High white blood cell count can also infer inflammation. C-reactive protein or sedimentation rate not just indicate active systemic inflammation if they are high, but is prognostic in that high values increase the risk for heart disease. And if there is uncertainty in the diagnosis, especially if the presentation is initially chronic inflammatory arthritis without obvious psoriasis, rheumatoid factor, anti-CCP, and even the anti-nuclear antibody may be necessary, especially in young females. No? Renal and liver function tests are always important to get in patients whom we will be giving medicines to. Hyperuricemia is usually seen in patients with psoriasis because of the high epidermal cell turnover. So it's quite common for patients with psoriasis to have gouty arthritis as well, further confusing the exact cause of joint pain in some patients. In those with psoriasis who present with arthritis and others in whom psoriatic arthritis is suspected, HLA-B27 testing may be helpful as it is one of the genetic markers that identify patients likely to develop PSA, even though it is not diagnostic. Additionally, spondylitis, risk of which is increased in the presence of these HLA-B27 allele may not be symptomatic at the outset. So it's important to note that laboratory findings in sore arth are non-specific, consistent with the degree and chronicity of inflammation. So acute phase reactants were elevated in only about 40% of patients. And there are no laboratory findings characteristic of sore arth that distinguishes it from other forms of inflammatory arthritis. But radiographic changes usually not seen in other forms of inflammatory arthritis can develop, and these include the coexistence of erosive changes and new bone formation. But we know that if it's erosive, it's usually rheumatoid arthritis. If there's new bone formation in the form of spurs, it's more likely osteoarthritis. But in sore arth, these two can coexist. So next slide, please. Okay, these are just radiographs of the spine. So this should be obtained if there is back pain. And this image shows sacroiliitis and destruction, as well as erosive bone formation. And additional imaging may be useful if there is uncertainty regarding whether enthesitis is present, such as ultrasound, if adequate expertise is available, or even magnetic resonance imaging or MRI. Okay. Synovial fluid testing is possible and should include cell count and differential, Gram-Stain and culture to rule out infections or septic arthritis, and crystal examination to check for possible gout or a coexistence of gout. And fluid in psoriatic arthritis is usually inflammatory. Okay, so timing is important, especially in diagnosing psoriatic arthritis. And this study showed that a delay in diagnosis of sore arth is associated with poorer long-term outcomes. In fact, more than 6 months delay is associated with increase in erosions on imaging, increase in functional disability, and these patients are less likely to be medication-free. The presence of arthritis mutilans, which is considered as the most severe psoriatic arthritis joint damage, was significantly associated with a diagnostic delay of more than a year after adjusting for the confounders. So let's now proceed to treatment. Dr. Mojica, how do we manage these patients when they present to us in the clinic?
So the treatment of psoriatic arthritis should be started early in disease and be coordinated between specialists. So let's talk about first na psoriatic arthritis, no? Before we proceed with psoriasis itself in the skin. So it is guided initially by an assessment of disease severity and most severely involved regions. So the target of treatment, as said by Dr. Jing, is remission or inactive disease or low or minimal disease activity. Patients should undergo pre-treatment screening for comorbidities and baseline testing and appropriate vaccinations before drug administration. So they should be referred as needed for prevention and medical management of comorbidities such as cardiovascular and liver disease and related risk factors. So there is no cure for psoriasis, but thankfully we can control the signs and symptoms associated with it in many ways. So when lesions are limited, we can opt to treat with topical steroids and vitamin D analogs. And the medications are usually applied 1 to 2 times a day for the next 2 weeks, and then we give a steroid holiday for another 2 weeks to avoid the loss of efficacy of the steroid. For more extensive cases or body surface area involvement is more than 10%, we can give systemic therapy. So methotrexate is the favorite DMARD of dermatologists in the Philippines. It's easy to administer, it's just in a pill, and most importantly, it is cheap. If you buy it in government hospitals, it's around 11 pesos. So for those who cannot tolerate systemic treatments and who have been on topical treatments for quite some time, a good alternative therapy is phototherapy. So in phototherapy, the patient enters a UV cabinet and stays there for a few seconds to an increasing length of time. The UV rays serve as an immunomodulator that helps reduce the inflammation in psoriatic lesions. And this is done usually 2 to 3 times a week for about 3 months. No? However, if there is joint involvement, even if it's just limited disease, we have to give systemic therapy. So this next slide picture shows you what a UV cabinet looks like. So You enter there, and there are multiple bulbs that will emit UV, and then our patient usually stays here for the first session, 30 seconds, and then increasing to 1 minute and 3 seconds. So newer therapies which dermatologists employ include already biologics. Previously, we do not use biologics, but now we've learned that biologics are very effective in controlling both psoriasis, the skin lesions, and psoriatic arthritis as well. So Dr. Jing will be the one to discuss biologics in detail.
Thank you, Dr. Winlove. So this, okay, so non-pharmacologic management first. So these strategies are also important in the treatment of psoriatic arthritis, and patients should be referred for physical and occupational therapy. They should be encouraged to exercise, referred for as needed for orthotics, and educated about joint protection, the nature of their condition, the effect of stress on their disease, and of course, proper use of medications. Patients should receive assistance in weight reduction and management of cardiovascular risk factors and other comorbidities, since these may lessen treatment response to DMARDs and or biologic agents. Okay, so the next slide will show the treatment recommendations by GRAPPA. So for most domains, NSAIDs or non-steroidal anti-inflammatory drugs are the first-line treatment to control arthritis, dactylitis, and enthesitis. And intra-articular steroids can also be used for peripheral arthritis, but for difficult to control ones, and since prolonged use of NSAIDs may lead to complications. No? So DMARDs may also be indicated in these cases. Biologic medicines are the most efficacious, however, especially when confronted with difficult to treat cases, and this runs across all domains. Okay, so dactylitis, skin, arthritis, etc. So Dr. Mojica already mentioned DMARDs, such as methotrexate, that could be helpful for our patients, both with psoriasis and psoriatic arthritis. And biologics available in the country include IL-17 inhibitor and several types of TNF inhibitors, which we can use in refractory cases. Or sometimes these are preferred by patients if they just want to get better immediately, no? And skip the prolonged efficacy that is expected if we use just oral treatment or topical treatment. So of note, and this is very important, use of oral steroids in patients with psoriatic arthritis should be avoided. And if this is required, for example, if there is a very severe flare, the dose should be the minimum needed, since their use is associated with an increased chance of developing erythroderma or pustular psoriasis. So in addition, there appears to be interference with the effect of other drugs. And this is different though from intra-articular steroid injections, which we sometimes need to give to our patients to address persistently swollen joints. But care should be taken in patients who require such injections to avoid injection through psoriatic plaques. Okay. So now we proceed with lupus. Okay, Dr. Winlove.
Yes. Okay. So we will now proceed to the second part of our talk. And this is another condition wherein the collaboration between a dermatologist and a rheumatologist is needed. So lupus is similar to psoriasis in that the development of LE has both genetic and environmental basis. Immune system activation in SLE is characterized by exaggerated B cell and T cell responses and the loss of immune tolerance against self-antigen. So the body cannot distinguish between self and non-self anymore. So production and defective elimination of antibodies, circulation and tissue deposition of immune complexes, and complement and cytokine activation contribute to the clinical manifestations that range from fatigue and joint pain to severe life-threatening organ damage. So if we simplify, the genes involved in LE allow the loss of the body's ability to identify self and non-self. So, and then there is a triggering event. Usually it is sun exposure. Once the UV rays penetrate the skin, it destroys some of the cells, releasing cellular debris, which the body misidentifies as non-self. So as you know, one of the things that we always advise our LE patients is not to expose themselves to the sun. So LE can be regarded to be in a spectrum. One end on the left side is mostly limited to the skin, and there's the other side, which involves the skin and other organs, no, with systemic involvement. There are numerous manifestations of LE, and the most common description is a malar rash. And this is an erythematous patch or plaque on the cheeks involving the bridge of the nose and sparing the nasolabial folds, which shows the photodistribution of the lesion. This cutaneous finding is associated with systemic disease or the systemic type of LE. There is, however, a type which is limited to the skin, and this is discoid LE, which is a violaceous, which has a violaceous hue and varying levels of atrophy or thinness. Other skin findings in LE include alopecia, mouth sores, photosensitivity, Raynaud's phenomenon, vasculitis, and even bullous lesions. No? The nails can also be affected in LE, just like in psoriasis. And on dermoscopy, when you put a glass slide on the proximal nail fold, you can find dilated capillaries in this area. And this is highly pathognomonic of LE and also dermatomyositis. So when a dermatologist sees a suspicious lesion of LE, a skin biopsy is usually ordered. And here, you will find a classic histopathologic picture of lupus erythematosus. You will see a lichenoid infiltrate of inflammatory cells, specifically lymphocytes, on the dermo-epidermal junction. And then you will see superficial and deep perivascular infiltrates, meaning the blood vessels in the superficial layer and the deep layers of the skin are also inflamed. You have inflammation around the hair follicles. You see the blue pattern around this hair follicle, and you see mucin in the dermis. There is some bluish tinge in the dermis, and that is mucin. So when you see this, this is characteristic of an LE lesion. So to complete the workup, we usually refer to our rheumatologist friend. So Dr. Jane?
Okay, thank you, Dr. Winlove. So as mentioned by Dr. Mojica, most patients with lupus show cutaneous manifestations, and conversely, all forms of cutaneous lupus erythematosus may later on evolve into involving other organs. So this is one of the more recent classification criteria of SLE, which an entry criterion of at least 1 to 80 titer of anti-nuclear antibody or ANA is necessary. We see here constitutional, hematologic, neuropsychiatric, mucocutaneous. So notice that there are many in this category mentioned by Dr. Mojica. There's also serosal, musculoskeletal, and renal clinical signs. And immunologic domains seen as results of a blood test include antiphospholipids, complement proteins, and SLE-specific antibodies, including anti-dsDNA and anti-Smith. And at least a score of 10 is needed for a patient to be classified as having lupus. So we have to remember diagnosis is different from classification. So this is mostly used for research purposes, but it helps us in the diagnosis as well. At least it helps guide us in our decision to say, this is already systemic lupus or not yet. No? So next slide, please. Ayan, saya na pala. So even in this latest edition of Harrison's, your book now, what is there is still this 2012 SLIC classification criteria. It's almost the same, except there is no graduation in the scoring system. For the SLIC, criteria are cumulative and need not be present concurrently. So a patient is classified as having SLE if she or he satisfies 4 of the criteria, including at least 1 clinical and 1 immunologic criterion. Or alternatively, if he or she has biopsy-proven nephritis compatible with SLE in the presence of ANA or anti-dsDNA. Okay, so to note, next slide, arthritis includes pain and swelling or tenderness in 2 or more joints, or at least for at least 30 minutes of morning stiffness. Okay. So Doc Winlove.
So for the management of lupus, lupus is like LE. Lupus is like psoriasis, no? It has no cure. If there is one important thing that we must know is that patients should avoid the sun, no? Aggressive sun protection, because the sun is usually the trigger for the flare of lupus. So the sun triggers disease activity, therefore aggressive sun exposure sun protection is a must. So wear protective clothing such as hats, sunglasses, long sleeves, use umbrellas, place thick curtains on windows, avoid going out, especially from 10 a.m. to 2 p.m. Where the UV rays are most intense, and wear sunscreen SPF 50 and reapply every 2 to 3 hours. So if you cannot do all of this, might as well just stay inside your house, no? So for limited skin disease, super potent topical steroids can calm the lesions. One systemic treatment is needed, especially for those who have already other organ involvement. Oral steroids and other systemic agents may be given, but usually we give this with the collaboration of a rheumatologist.
Okay, so complete sustained remission in SLE is rare, and the goals of therapy are as follows: to ensure long-term survival, achieve the lowest possible disease activity in our patients, prevent organ damage, minimize drug toxicity, improve quality of life, of course, and to educate our patients about their role in disease management. So patients require monitoring at regular intervals to help them achieve treatment goals. They often have multi-organ system involvement and may require multidisciplinary care. No, so this is the choice of therapy in lupus is highly individualized. So that's supposed to be this slide. So this is the common algorithm for the pharmacologic part, wherein patients are initially categorized to have either non-life or non-organ threatening activity or manifestation, wherein management is more conservative versus life or organ threatening illness. So if we go back to the slide prior to this, we see that the choice of therapy for lupus is highly individualized. However, in general, our patients with lupus should be given hydroxychloroquine or chloroquine unless these agents are contraindicated, and their benefits are broad and include relief of constitutional symptoms, musculoskeletal and mucocutaneous manifestations, and as well as decreased flares, thrombotic events, decreased organ damage accrual, and mortality. And in this slide that is presently being shown, we see that in patients with mild lupus, for example, the affectation is only the skin, or also the skin, the joint, and mucosal involvement, we can add NSAIDs or short-term low-dose steroid. For example, nothing more than 7.5 milligrams of prednisone equivalent per day. And in patients with moderate lupus involvement, defined as having significant but non-organ threatening disease, example, cutaneous or musculoskeletal or hematologic activities, we can add short-term 5 to 15 milligrams of prednisone or its equivalent daily, which is usually tapered once hydroxychloroquine has taken effect. A steroid sparer, immunosuppressive agents such as azathioprine or methotrexate may be required to control symptoms. So for those with severe or life-threatening manifestations secondary to major organ involvement, for example, the kidneys or the central nervous system, these patients usually require an initial period of intensive immunosuppression, or what we call induction therapy, to control the disease and halt tissue injury with high doses of systemic steroids. For example, intravenous pulses of methylprednisolone for about 500 milligrams or 1 gram per day for 3 days alone, or in combination with other immunosuppressive agents. So this initial therapy is then followed by a longer period of less intensive and ideally less toxic maintenance therapy to consolidate remission and prevent flares. So prednisone or its equivalent is also reduced as feasible and necessary. Okay, so several agents have also been used in patients with lupus or SLE who are resistant to more established therapeutic approaches. Examples include these agents which target B-cell pathways, belimumab and rituximab. There's also cyclosporin, which inhibits the transcription process that is normally associated with T-cell activation. So there are other therapeutic approaches under investigation in lupus. So SLE is marked by disease remissions and relapses. Next slide, please. And the 5-year survival rate has dramatically increased to more than 90% since the 1980s. But despite this, the major cause of death in the first few years of illness are still active disease or infection due to immunosuppression, while causes of late death include complications of SLE, such as ESRD or end-stage renal disease, treatment complications, and cardiovascular disease. So we're nearing the end of our discussion, but we would just like to share this case of a 42-year-old female who virtually consulted in January 2021. She had rash in the ears. She had easy fatigability, hand joint pains, but no swelling since 2020. And the rest of the review of systems and medical history were unremarkable, except for a history of lupus nephritis in her cousin who died in 2019 at the age of 25 years. Her obstetric history was unremarkable. So this was how her ears looked like. So this is discoid rash. Tama ba, Doc Winlove? And here were her workups. So ANA was positive at 1 to 160. She had anemia, leukopenia, and low early complement. C3 was low. The rest of the examinations were unremarkable. So given her family history and presentation, it was easy enough to diagnose her with systemic lupus erythematosus, and she improved with hydroxychloroquine and short-term low-dose prednisone. However, in October 2021, she virtually consulted again due to COVID infection. So she got infected, which we managed at home, and from which recovered after around 2 weeks. And then she virtually consulted again a few months later in February 2022, this time with a 2-week duration of a new skin lesion on the hands and some on her arms. And she said she was having bad dandruff. So she also complained of pain in the gluteal and low back area for the past months. She said that the pain never disappeared since her COVID infection, and these were the photos she sent. And because her symptoms were pointing to inflammatory back pain, and I wasn't sure if these were silvery plaques or guttate sore, I referred to a dermatologist and advised the patient to do a face-to-face consult if possible. So Dr. Mojica, would you like to share what you think about this case?
Yes, during this time, I wasn't seeing patients yet in person. And at that time, she was seen by another colleague. And I think the assessment then that it can be psoriasis. What I can say is that nothing is impossible. We can have 2 inflammatory disorders concomitantly seen in a single patient, so that we can report this. It would be best, if we'd be able to get a biopsy of these erythematous lesions with seemingly silvery scales to clinch the diagnosis. And I remember when I was a student, I thought I needed to know everything regarding the diagnosis of a patient, taking care of a patient. But when I went into residency, I learned that it takes a village to do so. And we need to be aware when something is beyond our expertise, and we need to be humble enough to seek the help of our colleagues. And personally, seeing this case and talking with you, Jing, in the last 30 or 40 minutes, I'm lucky to have found the network of doctors, and that you are included in that network, who value my expertise as a dermatologist, and who just don't think that we're just beauty doctors, but we are also part of the medical team. And also, at this point, I'd like to thank the Division of Rheumatology for acknowledging our expertise in this team. So, Jing?
Okay, thank you so much, Dr. Winlove, also for your time and expertise in managing our patients. And so to conclude our session, some of our, her other lesions. Okay, so in conclusion, some of our take-home messages.
First, there are many skin conditions that look alike. That's why you have to refer to a specialist if you are not sure what you're looking at. And then number 2, the skin is the window to the internal organs. A lot of the things that you see on the skin don't just stay on the skin. They tell you something that's happening inside the body of a person.
Okay, and psoriasis, psoriatic arthritis, and lupus are chronic conditions, do not have cure, but can be managed for a patient to have a good quality of life. And collaboration is key. And there are also support groups you can refer your patients to. This is the SORFIL. And then there's also Axial Spondylitis Association, or Axial Spondyloarthritis Association of the Philippines in the next slide. And for lupus, we have the Hope for Lupus Foundation, the Lupus Foundation of the Philippines, and Lupus Inspired Advocacy, or LUISA. So that's our last slide, I believe, Tama ba, Doc Winlove? And thank you everybody for your attention and for your interest in the topic.
Thank
Any
you.
last words, Doc Winlove? Thank you.
Thank you. Nice to see you and hope to work with you again. Thank you, everyone.
Thank you. So for your questions, we will be willing to answer if there are any.
Thank you.
Thank you, Jing and Winlove. And there are many questions to be answered, no? So we have a very, very interesting set of questions in the chat box, no? So let me jump into this because, as I said, marami talagang interest na napakita. Let's start first with the psoriasis questions, okay? Okay, let me go over them. So for those of you who still have questions, additional questions to ask, the Q&A box will still be open. If we're not able to answer your questions live, then we will be answering them in the chat. No? All right, now I just want to tell our speakers we have more than 400 attendees from Baguio to Sulu. So para na nating kakompetensya ang Eat Bulaga. So beware sila sa ating lahat. Okay. Okay. Let me start first with questions about psoriasis. No, one of the last questions asked is that, is psoriatic arthritis lifetime? Is it hereditary? No? So ano bang sagot natin doon, Dr. Jing and Dr. Winlove?
Okay,
Si
so
Jing muna.
start with saying that in a way it could be hereditary. There are certain genes or yung mga genes that we can pass on from generation to generation, from parent to offspring, that can influence the manifestation of the condition, psoriasis and psoriatic arthritis. So yes, it is hereditary, but it doesn't mean that if your parents have it, or if one of your parents has it, one of your siblings has it, then you would automatically have it as well, or that you would automatically pass it on to your children. It's not like that in its transmission, but it usually runs in families. So there is a genetic basis for this.
Yeah. Okay. Also to Jing, would you know if we have data on the prevalence of psoriatic arthritis among patients with psoriasis?
Unfortunately, we don't have Philippine data on the prevalence of the arthritis part, no, or psoriatic arthritis among patients with psoriasis. But worldwide, in general, about 30% of patients with psoriasis will develop psoriatic arthritis. And rarely, psoriatic arthritis appears first before psoriasis.
And the clues that you provided earlier is that patients who may have nail changes, no, we have to be very watchful of them. For those who have parang back pain, no? Back pain sometimes is not really identified, but those can actually be heralded.
Yes.
So ito naman, pahinga si Jing for our skin sensei, mahihirap na tanong. How can we differentiate skin psoriasis from lichen simplex chronicus, or can they occur simultaneously? Ano ba yung lichen simplex chronicus?
So lichen simplex chronicus is also a form of eczema. And the difference between LSC or lichen simplex chronicus and psoriasis is that psoriasis has an autoimmune basis. No, they may appear similarly, but one of the contrasting features is psoriasis is erythematous, mapula talaga siya. Lichen simplex chronicus can also have some variable erythema, but when you see a psoriatic plaque, you cannot mistake it because it's really red. And it has the silvery white scale, so that is the very pathognomonic lesion. Ano? It is an erythematous plaque with the silvery white scale on top. The lichen simplex chronicus is also a plaque, but it is usually not that red, and at this time, you will see accentuated skin markings because lichen simplex chronicus is a result of constant scratching and constant
Mm.
trauma in the skin. So you usually see LSC lesions at the dorsum of the feet of elderly ladies or at the base of the neck, no? Because of constant scratching, it becomes an erogenous zone. So those two are entirely different, but I understand why they can be mistaken for one for the other.
Yeah. So it can be tricky, no? So the key things is the degree of erythema and the silvery scales of psoriasis. But sometimes when it's really hard, that's why we have dermatologists. That's why we have well-trained dermatologists.
At the same time, ma'am, sometimes it can be tricky. So when you are faced with a lesion that is like a plaque and it is a bit erythematous, and sometimes LSC could also have some form of scaling, no? You look at the other predilection areas, especially the scalp. So if a patient usually patients present in a straightforward manner, no, if it's a psoriasis. But there are also cases when they don't present classically.
Yeah.
Meaning hilaw pa yung diagnosis. No? They're midway into being full-blown psoriasis. So what we do is inspect the other predilection areas. Don't forget to look at the scalp and also the elbows and knees because these are common areas for psoriasis. And never forget to inspect the nails because sometimes there might be mild scaling on the scalp, mild scaling on the scalp and the nails, and then you see salmon patches, nail pitting, and onycholysis on the fingernails. So your diagnosis towards psoriasis becomes stronger. Ma'am Hazel, if I may also add to the answer of Dr. Jing regarding inheritance of psoriasis. So psoriasis is indeed an inheritable condition, but as we explained earlier, it's like inheriting the genes, but the genes are not automatically turned on. Hindi siya laging nakabukas. So there's a triggering event that turns on the genes. And from experience, it is usually weight gain. And psoriasis is part of a syndrome, metabolic syndrome, no? And the metabolic syndrome includes obesity, high cholesterol, and then your propensity to develop diabetes, cardiovascular diseases. So one of the things that we tell our psoriatic patients or those whom we suspect to have psoriasis is stop gaining weight, lose weight, so that even if you do have the genes for psoriasis, this does not become overt psoriasis. Yeah.
So we really have to care for our patients with psoriasis beyond the skin, di ba? Hindi lang to hindi maganda. It's something that affects the entire body, no? Kaya nga mahirap ang training ng dermatologist, no? Hindi lang hanggang balat, no?
Yes.
Okay, idudugtong ko na to. So kanina, di ba, there was a differential, lichen simplex chronicus versus psoriasis. There's a question here, when should skin biopsies for psoriasis be referred to a derm path? Kailan ba kailangan talagang ng biopsy?
Okay, so the diagnosis of psoriasis is clinical, does not really need a biopsy. But for certain cases, like for example, hilaw pa siya, the diagnosis is not straightforward. Kumbaga parang may lesion siya here and there but you are not convinced, then you can biopsy a young lesion. Also for legal purposes, sometimes for example, if you want PhilHealth coverage, they would require biopsy. So these are the times that require a biopsy, but any dermatologist can do a biopsy. It's the reading of the slide that is assigned to a dermatopathologist. So a dermatopathologist's training is different from the regular pathologist training. Kasi yung mga pathologist natin, parang they will also do skin readings, but not as in-depth as a dermatopathologist.
So that's I think a good lesson. Any dermatologist can do the biopsy. So if you think you need a biopsy, you don't have to look immediately for a derm path. You ask your dermatologist, can you do the skin biopsy? And they usually know where to refer, right?
Yes, usually we know where to send, and then the results come back in, and then we relay that to the patient.
So earlier you alluded to weight gain, no? So there's a question here. Is there like a special diet for patients with sore or may have a family history of SOR, is there anything they can eat to avoid flares?
Okay. I'm I always like to put myself in the shoes of the patients. I don't ask my patients to go on a specific diet for whatever condition that they might have. Kasi masarap kumain. So what I do, even for diabetic patients, at tatanungin nila, Doc, or for patients who have eczema, no, usually they will say, I don't eat chicken, I don't eat hot dogs, I don't eat na preserved stuff. I say, we only live once and life is short. Go ahead and eat. But do it in moderation, no? Yung marunong magtakal. Kasi kapag hindi ka naman kumain ng, kunwari ng lechon, mukha ka naman kawawa sa party. So what I say, you can eat anything and everything that you want, but make sure the proportion,
Yeah.
there is portion control. And now there are apps that usually would be able to calculate the calorie requirements of an individual para hindi sila tumaba. So I asked them, you download this so that this can help you parang watch your weight, no, so that you don't gain weight. So I don't prescribe specific
No strict diets. Okay. So parang kuminsan nakaka-stress din for patients kung ang dami mong pinagbabawal, 'di ba? Like, oh my gosh, napakain ako ng ganito, and then they start thinking that something will happen. So maybe no strict diet, but we encourage everybody to eat healthy, 'di ba? And that's what I think.
Vegetables.
Yeah. Yan, maraming gulay. Matutuwa si Dr. Jing at ang kanyang snack na chicharon. Okay. Yan po yung snack namin kanina. Anyway, going on diet, ituloy ko na. What about immune boosters? Somebody's concerned about a friend of his who's receiving immune boosters. Do they actually work? Do we have data on that?
I actually saw that question and I researched on the immune booster. That immune booster is not really an immune booster. It contains an anesthetic, which is procaine, and dexamethasone, which is a steroid. And so any inflammatory condition will initially improve with the systemic steroid. Unfortunately, administration of systemic steroids is not good for psoriasis because it converts to a more difficult type of psoriasis, which becomes pustular psoriasis. So I would not recommend injecting that treatment. That is an indication for admission of a patient in a hospital if pustular psoriasis develops. So as of now, the real immune booster is lose weight, eat well, and exercise reasonably.
Okay. Tama, no? So, Jing, I think you might want to share what we see among our patients na naka-dexa na forever.
Sorry, ma'am, I didn't catch it. You were cut off.
Because earlier, Dr. Winlove said that sometimes the immune boosters are actually a combination of steroids and anesthetics, no? Might be good for us to describe what we see among our patients on chronic steroid use.
Okay, so can you hear me well, ma'am?
Yes.
Okay, so in patients who are given long-term high-dose steroids, we can see side effects such as weight gain or disproportionate gain of weight or fat accumulation in the face, such that it becomes like a moon fascies, weight gain in the trunk but thin legs. There could be increased blood pressure, increased blood sugar, and most importantly at this time, no, yung immune resistance, your resistance to infections is lowered. So there are many others, bone brittleness, etc., skin thinness. But the most important, I believe, for now would be the lower resistance of our bodies towards infections. And I would also like to comment on the terms, the immune booster, because di ba nga, we are talking about autoimmune conditions. So theoretically, if we boost the immune system, it can potentially turn against us. The immune system can be so boosted that it fights your own body. So I believe these immune boosters are just marketing gimmicks no, yung the way they term it. And maybe a better term would be what we usually tell our patients, like hydroxychloroquine is an immunomodulator.
Yes.
It moves the immune system. So it will recognize better what is foreign, what are the pathogens, and what is self. So immune modulation is better than immune boosting in general.
Agree. Agree ako dyan, no? Mas natural talaga yon for patients receiving steroids that they feel strong. That's why I think sometimes patients think na nakakalakas talaga yon. Pero ang dami na nating more short questions on steroids before we move on to the next mode. Ang dami talagang tanong. What about topical steroids? Pwede daw bang gamitin? And is there any use psoriasis or this?
Ma'am, sorry, choppy.
What about topical steroids? Is there use for them, or is there any use at all for systemic steroids with psoriatic arthritis?
Jing, sorry, Art.
Okay. When I mentioned earlier that it's not advisable for us to give systemic steroids like oral or injectable to patients with psoriasis, especially those with psoriatic arthritis, because of the possibility of pustular psoriasis occurring. It doesn't mean that it's a total contraindication, because of course there will be some cases wherein we will have to work with our dermatology colleagues. For example, I had a patient with erythrodermic psoriasis, very, very bad. And it was a reaction. Unfortunately, it was a reaction to one of her supplements. So I spoke with the derma colleague. Of course, we had to give her systemic steroids at that time because she was very inflamed, whole body, no, head to toe. And these are just some rare instances wherein, despite the knowledge that we should not be giving systemic steroids on patients with psoriasis, there will be these rare occurrences or instances wherein there's a need for an anti-inflammatory medicine, and steroids, low dose at that, would be our best, kumbaga, armamentarium at that present time, but with careful monitoring, follow-up. So it's not a total contraindication.
Yes, pero ang key doon is that the use has to be tightly regulated and monitored, diba? So, kailangan nakakausap ng maayos yung patient, no, about the benefits and the risks. Agree. Okay. Okay, moving on from steroids to UV light. Ang daming intriga dun sa picture na parang tanning bed daw, Dr. Winlove. So, what differentiates UV light therapy from sunbathing or early sunlight exposure? Pwede na ba yun?
Okay, so for individuals who cannot afford the UV narrowband UVB treatment, mostly located in big hospitals, sun exposure can replace UVB treatment. UVB treatment is a little bit more specific because the electromagnetic wave from the sun, there are different types of rays, and UVB is only one. So parang we're selecting the most efficacious wavelength to do immunomodulation for the skin. Now, you will also receive some form of UVB when you do sunbathing, but of course, you will also receive the other types of rays. No, just a word of caution: if you do sun exposure, that can also be a form of trauma. That's why for psoriasis patients who go to swimming in the beach, and then they stay under the sun until 12 or 1 p.m. And then after a while, you will see that they will develop psoriatic lesions in the distributed in the area where there was sun exposure. Tapos yung area na covered ng bathing suit, walang lesion. So that is a form of Kebner phenomenon. So if you don't have funds to do the UVB therapy, you can do sun exposure, but very, very early in the morning, like 6 to 8 in the morning. And after, stop na, you go inside. So in a way, that will also mimic the UVB treatment, but not as severe if you go under the sun ng 10 a.m. to 2 p.m.
So wag magpaka beach sun exposure, no? It's the gentle sun exposure with the early morning. Wow, that's good to know, Dr. Winlove, kasi that's really practical. I think a practical question that's being asked by a lot of our practitioners. Oh, ito, before we leave the issue on psoriasis and psoriatic arthritis, no? Patok na patok si Skin Sensei sa umagang ito. Dr. Jing, is there any harm in giving NSAIDs for sore arth along with methotrexate? Can you do that?
Yes, we can do that definitely. In fact, the first line for treatment of spondyloarthritis, such as psoriatic arthritis, for inflammation and pain control would be NSAIDs. And we do give this concurrently with methotrexate if necessary. However, we will notice later on that as methotrexate is improving the overall condition of the patient, we will need less NSAID use. But
Yeah.
if there is no contraindication like gastric ulcers, etc., then we can safely give them both together.
Yeah. Okay. So talaga pong ginagamit sila, no? First line treatment, as Dr. Jing said. Okay, I think that rounds out our questions on psoriasis. Let's now move on to lupus. So si Jing naman yung taya. But before we start with the questions, one of our guests put Mary Antoinette D. and Dan, my mom survived almost 40 years of having SLE. Yay! Very happy for you, Mary Antoinette. And let's connect that, no? Ano ba yung life expectancy daw among our patients with moderate lupus?
So, yung prognosis of patients with lupus, including the lifespan, is so much better today compared to before, no, compared to maybe 30 years before. And especially with close follow-up and treatment, of course, you have to always be following up with a rheumatologist. Up to 90% of people with lupus can expect to live a normal lifespan. So the key here is early diagnosis, continued treatment, and at present, there is still no cure for lupus, as well as maybe all the chronic conditions that we know. From what I know, infections lang na bacterial ang may treatment talaga or may cure. All the rest are just managed so that we can live normal lives. So for moderate lupus, as long as, I'm not sure how much the lifespan will be decreased, but if there would be remission eventually because of continued treatment with the rheumatologist, then we can expect a normal lifespan, at least for 90% patients.
Yes. Totoo yun, no? Hindi na before na if you have lupus, it's like getting a death sentence. Ngayon, ang pinag-uusapan na po namin is survival beyond decades, no? Ano yung mga concerns ng mga patients namin who've had lupus for 20 or 30 years. Okay. Sige. Moving on, maraming questions about SLE, Jing, no? Yung first is that, is it possible to have clinical manifestations of lupus and not have the immunologic manifestations?
For us to diagnose or at least classify somebody to have systemic lupus erythematosus or SLE, we should have at least one immunologic test that turns out positive. Now, if it's just clinical lupus, then maybe we should question if this is really lupus. Although there is cutaneous lupus, right, Dr. Mojica, but usually these patients will also have a positive ANA. And it's just that, no? So siguro, clinically, it could just be cutaneous lupus. But if there are other symptoms, for example, there is protein in the urine, there is a rash that looks like a malar rash, and other clinical signs, but then all your autoantibody panels turn out negative, including anti-SSA, anti-SSB, because it's rare for us to see patients with SLE with negative ANA, but there is still a small percentage, but will have usually a positive, show a positive anti-SSA or anti-SSB. I believe that we should, kunwari, no auto-antibody present, then maybe we should think of other differentials.
Yeah.
Because lupus is one of the greater mimics of medicine aside from tuberculosis.
Yeah. And sometimes it's a matter of time, di ba? When we evaluate patients with all of these symptoms, yung parang mukha talagang discorded, di ba? Parang ganun. Sometimes it's a matter of time and we just really have to be patient in monitoring the course of our patients, no? So, very important yung continuity of care, di ba?
Although we also know that usually the autoantibodies appear first, and it usually takes about a mean of 5 years before this become clinically manifested. So if it's florid, that the patient has symptoms, joint pains, etc., then maybe it's not lupus. That maybe it's another inflammatory arthritis. Maybe it's psoriatic arthritis. So baka yun yung possibility.
Tsaka hanap din tayo ng, aside from looking for other differentials, di ba? Kung minsan, we also have to consider how the serologic tests were done.
Yes, that's also
Oo.
very important. You're right,
Kaya,
ma'am. So,
kung minsan pinapaulit.
so it should be of good quality. The ANA should be immunofluorescence in method, not latex. Preferably immunofluorescence over ELIA method, so that the result would really be more believable,
Yeah.
kumbaga.
So ito, going to ANA, the question is, what is the difference of ANA screening versus ANA titer? Meron bang difference yon? Ano ba yung ANA?
So ANA or anti-nuclear antibody is just one of the antibodies that can form against a part of the cell. So anti-nuclear, so anti-nucleus. When we say ANA screening in rheumatology, what we really mean is we want a titer to be, we want the ANA to be tested against a titer of at least 1 to 80. Because for us to classify a patient into having lupus, there should be an ANA positive test, at least 1 to 80 titer. So the higher the titer is, for example, a patient has an ANA test that is positive at 1 to 1,280 na titer, then that means that it's more likely that this is a true positive ANA test. For example, a patient has a positive ANA test, and we get a lot of this in the clinic. Positive sila ng ANA, 1 to 40 or 1:40. And they already panic. Doc, am I going to die? Do I have lupus? And then you have to reassure them that at this titer, about 30% of people without lupus or without any clinical condition can have a positive test. Or this could be positive because of an infection, cancer, or others. So the titer simply helps us say if this is more likely a true positive test. The higher the titer, the truer it is as a positive test.
Talk about the screening test. Sometimes it's titered, sometimes it's not. So baka doon na gagaling yung confusion ng audience. So mahalaga rin maintindihan natin yung test procedures actually na ginagamit, no? So Jing, kanina somebody asked about exactly, Dr. Manahan, na ANA screening refers to slide latex method used by some laboratories. No? So that's why we have to pay attention to the actual test that was done. So kanina, Jing, somebody was asking about, can you have symptoms but negative serology? What about you have symptoms but you're not sure? Like, how do you know, Dr. Winlove and Dr. Jing, I have some joint pains, tapos parang feeling ko dami ko naglalagas na hair. Kailan ba yun significant? Kailan ba ako magpapanik?
Okay. So before we started the webinar, we kind of discussed that, no, hair fall. There are many reasons for hair fall, and it is normal for a person to lose about 100 strands of hair a day. So if patients are really anxious about their hair fall, we really ask them to count and put it in a plastic bag or wrap it in an envelope and count per day. If it's more than 100, then that is pathologic. Now, the more common causes of hair fall will be telogen effluvium. So telogen effluvium is a condition wherein parang you'll have an inciting agent, an infection, a traumatic experience, an operation, or a viral illness 3 months prior, and then 3 months later, your hair will fall, no, sabay-sabay. And usually this resolves in about 6 months. So if we see patients who have hair fall, we ask them, parang nagkasakit ka ba? And usually, nagka-COVID po ako 3 months ago. So very common yung hair fall sa COVID patients, no? Also, kunwari, nanganak po ako, tapos 3 months later, nag-start maglagas ng buhok. Now, if there is no antecedent or inciting event that can be identified, and there is easy fatigability, and there is questionable history of photosensitivity, that is the time that I refer to a rheumatologist to do the blood works, because we cannot do a biopsy because there are no visible visible lesions. So we refer to a rheumatologist.
Yan. So, exciting. Ang dami pa nating tanong. Dr. Winlove and Dr. Jing will answer some of them in the chat, no? But here, let's help a colleague. OPD patient daw niya, HCQS and PRED, 5 years without flare, on regular checkup. How do you monitor, and should the meds be continued? Jing, I think this is for you.
So we can monitor clinically, but if there's really no symptom, of course, we have to get from time to time at least a blood count, a CBC. We have to check if there's anemia, if there is leukopenia, because sometimes patients don't show clinical manifestations, but their blood count would show otherwise. You can also check the urinalysis. Actually, it's imperative that we check the urine from time to time. If there's no proteinuria, no red blood cells, clean, then that's good. We can also check C3 and or C4. These are early complements, and these fall or become lower in patients with active lupus or magiging active pa lang. So if those are all okay, no anything clinical signs and symptoms, then maybe the patient is really indeed in remission, and we can possibly stop her medications. At least
Okay.
taper off prednisone for a while. That's probably what I would do first.
Yes.
Taper off prednisone.
Minimize the PRED, no? Carefully
Yes,
and slowly. Yan. So go. Ito fast answers, ha? If lupus patient in remission for several years, pwede bang maging active umulit?
Yes, pwede, because anything that triggers it to flare, infection, stress, sunlight, can trigger that flare. So yes,
Yeah.
parang boy abunda to ngayon, no? Fast talk.
Yes. Pwede bang male lupus?
Yes, pwede. So
Yes,
the
na
ratio
yes.
usually is 9 females to 1 male, more females in the reproductive age, but more males can also be affected. Also older people, and also children, not just young females.
Ito. Can lupus be a factor in development of heart disease or neurologic illnesses? We were talking about chronic course, no?
Yes, especially for heart disease. It's actually the most common cause of death in lupus with long-term lupus. That's why it's
After
important
10
for us.
years.
That's why it's important for us to tell them about their diet na good for the heart, not necessarily for lupus, but for the cardiovascular system.
Yeah. Is
Less
it true that
sugar.
stem cell can cure lupus, Dr. Jing?
No, systemic sclerosis has been found to have a stem cell therapy for systemic sclerosis, but not for lupus.
Not yet
Marketing lang
for
yun.
lupus. Not yet,
Not
no?
yet.
Tingnan natin.
Maybe in a
Yeah. Okay. So here, more fast questions. Is there a role? Do you need to give vitamin D for patients with psoriatic arthritis and monitor it? So maybe Dr. Winlove, do you give vitamin D? And Dr. Jing, do you monitor?
We give topical vitamin D, but not necessarily the oral form of vitamin D. Like I said, sun exposure is usually good, no, to activate vitamin D, but unfortunately, it can also be a trigger. So, based from experience, we don't give oral vitamin D supplementation for psoriatic patients.
Okay.
systemic vitamin D has been shown to improve the immune system or decrease inflammation, but of course we have to monitor the level first. Although there is debate on that. At the very least, we can just make sure that they're adequately, the level is adequate.
So, how common is psoriatic arthritis and axial joints? Not very common, but it happens, di ba, Dr. Jing?
Yes.
Okay, tapos, okay. Itong iba kasi very specific, hindi na namin sasagutin, ha? But I think this is important. Does HIV infection increase the risk for psoriatic and psoriatic arthritis? Winlove, I know you'd want to take this.
Actually, baligtad.
Yes.
patients who have HIV have an increased risk of developing psoriasis and psoriatic arthritis, simply because the pathway for both diseases is the same. No, they both affect the T helper cell. So when the T helper cell gets crazy because of the virus, it does not automatically kill the cell. No, it can drive that cell crazy, and the cell can produce a lot of inflammatory cytokines. And unfortunately, T helpers have been found to be the center of the development of psoriasis when they produce mga IL-23, IL-17, so they can develop psoriasis. So the new onset of psoriasis in a middle-aged male in the Philippines can be a clue that this person might have psoriasis. So you can do your sexual history and just be more thorough with your history.
Yeah, and we've seen that actually recently, no? Like recent onset, very explosive psoriasis when we screened the patient actually was HIV positive. So ito, Jing, last question for you. When do we use golimumab? And what's the best time to use it?
Golimumab is a biologic medicine, anti-TNF, that we use in patients with refractory psoriasis or psoriatic arthritis. Those who do not respond well to methotrexate and other therapies.
Yeah.
So it's not just golimumab, it could be other anti-TNF or even an anti-IL-17.
And how long can we treat patients? Somebody was sharing that her mom was on HCQS, changed to methotrexate, now has osteoarthritis. Very typical, no? Nagkakaroon naman po, dahil nag-age din po yung patients natin. How long can they take medications of this sort?
Oh, they can take it as long as they're alive and they need the medicine. But of course, we have to continuously monitor the patients for possible adverse effects or maybe changes in dose or maybe changes in medications.
So beautifully said, Jing. Okay, ito. Dahil lunchtime at bago tayo magbukas, Dr. Winlove, ano yung daily calorie intake app that you're using?
Okay. So actually marami siya, but what I find most useful is yung MyFitnessPal. So you are able to log in your daily calorie intake. So makikita mo kung 1,500 calories or 2,000 calories. It will help you identify yung food, no, yung calories ng food. MyFitnessPal.
MyFitnessPal. At wala pong product placement ang MyFitnessPal. Okay, it's been the most interesting exchange. We still have 350 participants in the Zoom, no? So I guess it's an interesting topic and interesting questions for everyone. Thank you for our audience for all of those. Thank you, Winlove and Jing, for answering our numerous questions. We counted 46. I'm sure the audience learned a lot from you today. Thank you, audience, for being so alive. This afternoon, we learned that there's really a significant overlap among rheumatologic and dermatologic conditions. Some patients will manifest first with cutaneous lesions before articular manifestations or vice versa. So therefore, a good history is actually very important. And Jing and Winlove shared with us some simple tools to help us in identifying this, including, for example, PEST for psoriatic arthritis. And why do we need to do it? Because early identification of these conditions matter in terms of patient outcome. No? Nakakaganda ng buhay ng pasyente. And how can we do it? There is really much to be gained by working with our colleagues, specialists. So maraming salamat, Winlove, for sharing your expertise with us today. So on behalf of the section, we would like to thank our speakers, as well as the Information Management Network team of UP Manila and our sponsor, Pfizer, for making this possible. Thank you all for joining us. We hope to see you again on September 15 for another informative and timely lecture regarding juvenile idiopathic arthritis and rheumatoid arthritis. Again, our books, the Atlas of Rheumatic Disease in the Philippines and the Telerheumatology Toolkit are available. So let us know if you're interested to have them. And please do join us again on September 15 Rheuma the Young and the Young Ones. Have a great rest of the day, everybody. Be safe.